And welcome back to Oncology Here and Now, an oncology podcast that goes over some of the most relevant and hot topic in oncology. My name is Elisa Agostinetto. I'm a medical oncologist and research physician at Institute Jules Bordet in Brussels, Belgium. And today I have the great pleasure to be here with Professor Maryam Lustberg, medical oncologist from Yale Cancer Center, and we will discuss probably one of the most highly debated also topic in breast oncology that concerns the role of adjuvant CDK4/6 inhibitors for hormone receptor positive, HER2 negative early breast cancer, and also how to choose the best adjuvant CDK4/6 inhibitors in each specific clinical case. So first of all, Professor Lustberg, thank you very much for being here with us today. Would you like to introduce yourself for our audience?
Yes, good day, everyone. Thank you for having me. I'm Maryam Lustberg. I'm a breast medical oncologist at Yale Cancer Center, and so happy to be here with you today.
Thank you again. So let's get into it. And I will start with a question that probably addresses a little bit the elephant in the room when we talk about adjuvant CDK4/6 inhibitors in the adjuvant setting. So we know that so far we have two CDK4/6 inhibitors that are approved for use in the adjuvant setting for patients with hormone receptor positive, HER2 negative early breast cancer. And these are Abemaciclib, based on the results of the monarchE trial, and the Ribociclib, based on the results of the NATALEE trial. We know that the eligibility criteria of these two clinical trials were slightly different. So also the indications to use the two adjuvant CDK4/6 inhibitors are slightly different. And we may say that it's easy to assume that in case of non-overlapping indications, we will use or we will consider to use, of course, that CDK4/6 inhibitor that is approved for that specific indication. But what about those cases that have overlapping indications to both adjuvant CDK4/6 inhibitors? How would you suggest to choose between ribociclib and abemaciclib for those patients that are actually eligible to both agents?
This is a wonderful question. It happens in clinic all the time. I just had one situation this week even. And in the situation where a patient is eligible for both agents, I think different clinicians are approaching it differently. In my practice, I think it's important for the patient, first of all, to know that there's two approved agents. And I spend some time summarizing, the clinical outcome data with both agents, and spend more time actually talking about the different side effect profile of both agents. And really try to involve patient as much as possible in that shared decision making. And I think there are definitely patients who have strong preferences in terms of one toxicity profile over others. So that's one element of things. Second is to kind of summarize that we have longer length of follow-up data, certainly with abemaciclib from the monarchE data. So I do also share that with patients. Number three, it does sometimes come to insurance coverage in the US at least, in terms of the type of medication coverage that a patient has. So putting all this together, I think ultimately, it's wonderful that we do have choices. And I think involving our patients in that discussion is very important.
Yeah, I can say that I totally agree with you. And indeed, as you said, safety has a crucial role, of course, in this discussion. And for all those cases where indeed there are no major safety contraindication to one or to the other, discussion with the patients is of course crucial and of paramount importance to decide the best agent. And as you said, it's also very important to remember that indeed for the monarchE trial we have a more mature data and a longer follow-up. This is also indeed important to be considered. I have another question, if I may, and this is of course something that we are facing more and more since we use CDK4/6 inhibitors in the adjuvant setting, and it concerns how to manage those patients who experience a disease progression during adjuvant CDK4/6 inhibitors or soon after the end of treatment with an adjuvant CDK4/6 inhibitors. So what would you suggest as the best treatment strategy in first line for these patients? And if you may really consider the two scenarios of patients with the disease progression during adjuvant CDK4/6 inhibitors, or in case of a disease progression occurring after the end of treatment with an adjuvant CDK4/6 inhibitors.
Great question. And even though with adjuvant CDK4/6 inhibitors, certainly we have seen a reduction in these scenarios, we do still see them. And so these patients are showing really a more aggressive hormone receptor positive biology with these early recurrences. So I think it would be important in the scenario, in both scenarios, to understand the drivers of tumor progression. Some type of a tissue sampling to certainly confirm metastatic disease, and then further sequencing of the tumor, or if that's not possible, also a liquid biopsy would also be important. So understanding the molecular profile of the tumor, particularly the PIK3CA status of the tumor, would be very important to drive decisions for next line of therapy. I would expect ESR1 mutations to be relatively low in this population, but that would be also an important piece of information to have. And then understanding somatic and germline alterations in DNA repair would be that third piece of molecular profiling that would be very actionable. So putting all this together, I think there will be approximately a third or more of these patients that do have a PIK3CA alterations, and I think directing them toward essentially an AKT inhibitor with the approved agent capivasertib, and certainly we also have the older PIK3C inhibitor with alpelisib. So kind of directing them to that type of a molecular-based therapy and changing their endocrine therapy partner depending on what they progressed on. If it was an aromatase inhibitor in this situation, we would switch to fulvestrant. So there would be a standard approach. If they don't have molecular profile, certainly actionable molecular profile, certainly changing their endocrine therapy partner, looking at clinical trials would be important. There are triplet combinations that are being studied. There are many studies looking at this, including Capitello 292, which is looking at the combination of capivasertib, a CDK4/6 inhibitor, plus fulvestrant in this type of population. And their progression on a previous CDK4/6 inhibitor, it needs to have happened in the last 12 months. So we would have to look at kind of eligibility for Capitello 292 or trials like it. But there are patients that this is actively happening on a CDK4/6 inhibitor, and I think that's the second scenario that you mentioned. And I think these are not necessarily patients that would be eligible for many of our clinical trials. And I think, again, back to understanding their molecular biology and hoping that there is something actionable that we can direct them to. In a case of a tremendous near visceral crisis, this would be also a patient population that we need to kind of start thinking about maybe different drug classes, including antibody drug conjugates. So it really does depend on both the disease burden, the velocity of disease, their molecular profile, whether they completed their CDK4/6 inhibitor and at least had some time being disease-free, or whether it's actively happening on CDK4/6 inhibitors. So it's an important question that you're asking, and I think it will depend on many of these factors.
I think it was a very, very clear your answer. Thank you. And I will conclude with another difficult question, and this is a difficult question because we do not have many data available, and it's about male breast cancer. So we know that male breast cancer is quite a rare condition. It happens in less than 1% of all breast cancer diagnoses, but it exists and it may happen in our clinical practice. So my question is whether all these considerations that we did around CDK4/6 inhibitors still apply the same to male patients with breast cancer, or if you would advise differently, or if you have any suggestions for clinical practice in this specific topic.
As you mentioned, many of our original trials unfortunately excluded male breast cancer, and given the rarity, the amount of data that we have on this population is less. In 2019, the US FDA actually recommended inclusion of males in all breast-related trials. And we also have guidelines from the American Society of Clinical Oncology that were published in 2020 in the Journal of Clinical Oncology, again, reminding us all that we can mirror and extrapolate from female breast cancer data and use agents similarly, including CDK4/6 inhibitors in male breast cancer. However, in the adjuvant setting, I think there's a few considerations in terms of drug-drug interactions. We typically use tamoxifen more commonly in male breast cancer that's hormone receptor positive. And I think tamoxifen and ribociclib, there is a contraindication now with recognition that there is increased risk of elevated QTc prolongation, which can increase the risk of cardiac arrhythmias. So I would have some caution between tamoxifen and ribociclib. We generally have stopped using that as a combination. For tamoxifen and abemaciclib, this was about less than 1% of the population in the monarchE trial actually did include males. And with tamoxifen and abema, we do see a slightly increased risk of thromboembolic events when both agents are combined together. I can say it's a doubling of risk, but if we actually look at the absolute numbers, we're looking at 2% with aromatase inhibitors alone and 4% with the combination. So I think it's important to put the absolute risk in the context of our conversation. So for a male breast cancer who's high risk enough to be receiving adjuvant CDK4/6 inhibitor, I think the question becomes, do we want to stick with tamoxifen and use it in conjunction with abemaciclib, in which case we would counsel the patient for their thromboembolic risk factors and make sure they don't have other risk factors? Or do we want to not take that risk, but take the additional toxicity of adding a GnRH agonist in combination with an aromatase inhibitor, in which case we could then use either CDK4/6 inhibitor. So that has not specifically come up in my routine clinical practice, that specific discussion, but I think it would be really important to, again, inform our male patient of those two scenarios, the risks and benefits. with a GnRH agonist, we worry more about additional quality of life effects, including sexual side effects and other toxicity. So I think it will be an important discussion to have to go through all those possible options. We do, you know, we like to think of hormone receptor positive breast cancer as the good biology breast cancer, but I think it's really important that in the last few years we've really begun to recognize that there are a group of these tumors that both can have early recurrences as well as late recurrences down the road. So as we get more sophisticated in our thinking of the tumor biology of breast cancer, I think a lot of the questions that you're asking will even become more multi-layered in the coming years. And I'm glad that we have clinical trial data to be guiding some of these decisions. So continue participating in clinical trials, because I think we need more answers.
Yeah, this is a very important remark. Thanks again, Professor Lustberg, for your insights and for this very nice discussion. And thank you all for listening to us, and see you soon.